There you go.
All right. So first of all, welcome. I'll introduce myself first because I already started talking. I'm Carolyn Francavilla. I'm a family physician and obesity specialist. I own Green Mountain Partners for Health, which is a family medicine and obesity practice here in Denver. I created the obesity medicine startup course and toolkit, as well as the obesity essentials mini course. Now have the Dr. Francavilla show podcast about weight and health that is more for patients. I do a little bit of teaching. I'm on the OMA board and I am the chair elect for the AMA's private practice section. So really love treating patients for obesity, but also love helping physicians get into the obesity space, as well as supporting private practice. And Kevin?
All right, so I'm Kevin Smith. I'm a internal medicine physician, and I also do obesity medicine as well. I'm here in Oklahoma at University of Oklahoma, here in Tulsa. I do obesity medicine, private practice, and also some hospital medicine as well, so kind of a variety of things. A couple years ago, I wrote a couple of books to help out with anyone who wanted to go ahead and take the ABOM boards and help out with that process. I have some background as a director of a question bank as well, and so that's kind of where my passion came from with that. And so I also do some free blogs that come out weekly. We just started the new season this last week to also help out with high yield board review related to the ABOM boards.
Awesome. So I like to think like Kevin is your go-to to help prepare for the exam with those test questions and his blog. And then I'm kind of like on the other end where you're like, okay, how do I actually implement this in the real world? And so we pair up great to kind of talk about what it's like to get in to the field of obesity medicine, how to prepare, the plus and minuses of the exam. I think it's worth noting that neither of us work for ABOM. So this is just us talking about this because we have both gone through the process and are passionate about the practice of obesity medicine. All right, so these are some common questions. And again, pop any of your specific questions into that chat or Q&A function. But we'll start off with, is practicing obesity medicine worth it? What do you think, Kevin?
Absolutely. I think this is one of the things where it really becomes addicting, because you have patients that come in, they have lots of chronic medical conditions. You start treating the underlying condition, which is generally obesity, and those chronic conditions get better. The patients come back, they're happy, they're excited. It kind of starts a cycle of the patients just being extremely satisfied and happy, especially when you can start to reduce some of those medications down. So I enjoy it. I implemented both, obviously, in the obesity clinic as well, but in my private practice. And I think that's been one of the funnest things is being able to just apply it to any patient wherever they're at, and be able to see the rewards on that. And so it's probably my favorite thing, regardless of what I'm doing, is when we can incorporate that component in and we start to see results and the patients get excited.
Yeah, I think everyone in our field that you ask that question gives kind of that same answer, where they're like, this is fun and it's rewarding. So my answer is pretty much the same. The second I saw this, I knew this is what I wanted to do, because you're actually solving a lot of the underlying issues, right? Instead of adding more medicines, sometimes you might add one more, but you're often getting people off of medicine, and you're avoiding heart attacks and diabetes and amputations. And so it's so rewarding to see those changes, and your patients are happy. They are so happy to have like real solutions and to have progress and to have someone who supports them. And I think that's a really fun part of medicine. Medicine is often really emotionally draining, and this is definitely an emotional field at times, but I think our patients are so happy. I always tell, people, this is like the happiest field of medicine. If you go to our conferences, people are excited, they're energized, they love the practice of medicine, they like collaborating. And I think it's very different than a lot of how medicine feels right now. So I think it's fantastic from both a patient standpoint and from a career standpoint. I think obesity doctors are usually really happy with what they're doing.
Yeah, it definitely prevents burnout. I feel like if you're just up against the fight of chronic diseases, and you're just kind of putting medications on sometimes symptoms. Once you hit that underlying condition and treat that, you don't feel as burnt out. You feel excited. It's energizing for sure.
So So a question that people will sometimes ask is like, can any specialty practice obesity medicine? Can I come from like radiology? Can I come from OBGYN? Can I be a surgeon? Where can we come from and do this? And anyone can do obesity medicine, and anyone can actually take that board exam. You do always have to, as of right now, maintain your primary specialty. So if you take the obesity exam, it doesn't mean you can stop taking your family medicine boards or stop doing whatever ABIM makes you do. All those hoops, you still have to maintain your primary certification in a field. So the ABOM really sits on top of whatever your primary specialty is, but any specialty can do obesity medicine. And we definitely get some interesting backgrounds for people who just find this and find a passion for it. It's not all primary care, though I think, primary care is a big driver of who practices obesity medicine.
And so even, I do some inpatient medicine as well. And you may not be treating in the same way as far as, someone coming in to an obesity clinic and working on that in a longer term basis. But I think it factors in, especially when you're talking about new medicines that you may be starting from the inpatient side, which ones are obesogenic and which ones to avoid, what are some alternatives. And so there's all these different areas that you can fit it in regardless of your practice location as well. And you can really have an impact and get the ball rolling. And if you do only inpatient medicine, knowing who's out there that's practicing obesity medicine, that you could potentially have that discussion, initiate it, and then pass them along to someone to do that continuity component as well. I think a lot of patients, they want to hear about it, but they may be kind of nervous too. So asking if it's okay, bringing it up, and then helping them out as far as letting them know what are some valuable resources within the community that they can send their patient to an outpatient setting.
Yeah. So just for anyone, like getting more comfortable with having these conversations with patients is definitely huge. And I think, obesity medicine is not everyone's full-time job. There are certainly, physicians who, once they get into this field, it's all they want to do. But many of us still practice sort of our primary specialty. So I still do family medicine, Kevin's still doing primary care and hospital medicine, it sounds like. So it's not limiting you to only doing obesity medicine. Once you start, you can just add it to what you're doing it. You could do it completely separately. Like I said, there was a radiologist who was going to start an obesity medicine practice as a side gig. It was his passion. I warned him he may not make nearly as much money as he does as a radiologist, but he really was passionate about it. And then, I have colleagues that, maybe they work at an eating disorder center like half the week, and then they have their obesity practice half the week. So lots of flexibility with how you incorporate, I think, obesity medicine into your career, whether it's just adding it on top, doing it full time, doing it as a separate side gig or a part-time thing. Lots of different options there. So moving a little bit more into the ABOM exam, a lot of people will ask if they need to take that exam or be a diplomate of the American Board of Obesity Medicine in order to practice obesity medicine. And I think that that's not realistic at all. We need all hands on deck to treat obesity. All physicians should have some, I think, competence level in having these conversations, or at least referring patients to the right place. But even if you wanted to do this as a large part of your practice or even full time, you don't need the exam to be able to do that. It's in the purview of, primary care. It's probably in some way in the purview of your specialty, as long as you're kind of staying within what you know and how to practice, which I think we all are very aware of how to do that as physicians. So you certainly don't need to take the exam. I think the exam can definitely add a lot of credibility. I think that as people are recognizing this field and they're starting to be job opportunities, which when I got into this, like, it was make your own job. There was no, big telehealth companies hiring physicians for this, that there may be more institutions and companies that actually require it. So that may be something looking into the future where it may be something people are asking you to do if you're looking for employment. I think it definitely adds to that credibility when you're networking, to explain that you do have a certification and a board in this field. So I think that's a huge reason to do it. Certainly if you want to do research in this field or be promoted academically, like, those may all be reasons to take the exam as well. But I don't think it should limit anyone from practicing obesity medicine, because again, it's probably within the scope of what you're doing, and we need as many people as possible trained to treat obesity.
Yeah, I would just add to that there's a lot of great clinicians that are out there that aren't eligible to take this exam either. So it's only eligible to American and Canadian physicians, MD or DOs. And so there's a lot of great practitioners out there that do an incredible job in the obesity field and really are up to date on their game and just fantastic clinicians. So it does have a limitation in terms of that, but you can see the quality of other practitioners that are out there that are treating patients and they've done the research, they've looked into it, they've learned more and continue to do CMEs just to gain that knowledge. And I think that's really an important part as well. I would say if I wasn't forced to take an exam, I probably wouldn't study certain things for the exam either. So me being in internal medicine, I probably wouldn't look at the pediatric stuff, but lo and behold, I think we have diagnosed and treated a number of patients who have Bardet-Biedl and different genetic conditions that usually present in pediatrics, but may not have been caught until a little bit later, just because genetic testing is now much more prevalent. And so being aware of what's out there, like I said, things that I probably wouldn't spend a whole lot of time studying if I were just to go out and do it. But when you take an exam, you're forced to learn everything on the test content. And so I gained a ton of knowledge just from that alone. And it really expanded my breadth of knowledge as well. And so I think there definitely is a component to taking it that really just adds to your knowledge and kind of forces you maybe into areas you're uncomfortable with, but in the end, it definitely is worth it in that aspect as well.
That's such a great point, that it really does make you dive into the neurobiology. Like you said, maybe pediatrics, if that's not something you would have studied on your own, nutrition, really, diving into some of the nutritional deficiencies, and very specific genetic syndromes, things like that, that again, if you're just focused on what you need to know clinically, you may not spend much, if any, time on. And so I think that is a great point, that it really does make you get a little more academic about it, get a little more structured. And by going through that process, you have a really, really good foundation of the medical background to be a really proficient clinician. But I think it's a great point that I tell people all the time when they ask this question. There's lots of great clinicians out there who are practicing obesity medicine who didn't take the board. Some of them are physicians, some of them are nurse practitioners and PAs. And, there is a lot of really skilled clinicians out there who didn't take the exam. So don't let that limit you from obesity medicine. But again, I think it is a credential that more people might be looking for in the future. And the process, you will become confident that you really know all the essentials for obesity medicine. So Kevin, I'm going to let you take the first stab at preparing for the ABOM exam, because you have taken it much more recently than me. And, you wrote like the Q bank for it, basically. So tell me how to prepare for the exam.
So yeah, when I was first getting ready to take the exam, I took it in 2021. It was kind of the post or around the COVID time. And so it was planning to take a little bit earlier, but it got pushed back a little bit because they didn't know how to take the test before it went to kind of the home testing environment. And now it's back to in testing centers. But trying to prepare for it, I did a couple of things. One, I went through a lot of the OMA slides and CMEs, and they also have a great board review program. And I really think that was just incredibly put together. And so those were some areas. Like most exams, I like to do Q banks and do lots of questions. And one thing I found out is there's really not a ton of question banks out there for this. And there's especially high quality question banks that are out there. And so that's one of the reasons why I decided that I would take kind of my background in writing questions and start pursuing writing a Q bank for this exam. And so pretty much as I was studying for the exam and going through different topics, I was writing questions kind of on the side, organizing information, putting it in tables and things like that. And at the end, had I think the first edition I had 185 questions in that blue book with explanations that had images and things like that. And so that's kind of how I helped me study. And anything that honestly, I went through all of that before I took the exam, and I used that primarily as my exam tools. It was all my notes and everything kind of organized. And then after that, I just kind of expanded out on that. Any questions that I saw or any topics that I didn't have on that in my list, I added it to. the book. And so ended up now we have 2 books, the blue book and the red book. And it gives around 525 questions total for the exam to study for. And so all of them are based off of high yield topics. And it could be question banks. I've gone through a number of different question banks and stuff that are out there through different organizations, as well as the board review programs on a number of different organizations that are recommended by ABOM as well, and kind of just conglomerated that all together and made a book out of it. So that's how I studied for it. I think question banks just let you know what your deficits are, and if you can have a good explanation that has information tables and set up in an organized way, it can help you prepare for questions that are similar to that and really excel on the test. And so that's how I prepared, and kind of how my books ended up being developed, and how I developed them along the way too.
I can't believe there's that many questions now. That's amazing. I think there's like 36 or something when I took the exam. So that's like such a tremendous resource. I also did the OMA board review course. And it was on CDs back then, and I listened to them on repeat in my car. And anything that I felt like was a sticking point, I would kind of draw out, especially like some of that neurobiology stuff, and just reviewed. And there's some stuff like demographic sort of population stuff and some of the vitamin deficiencies and the different syndromes that was like a little bit more, flashcard memorization sort of stuff before the exam. But I really found that the review course for me had everything I needed to know. And then it was drilling down on some of the ones that needed a little more studying or memorization. But I think the board review courses really are key for passing the exam.
Yeah, totally agree. The OMA one, I've listened to it the last 3 years now, and it really does. I mean, it covers everything in terms of what you need to know, and so organized in a great way. There's also the obesity algorithm that's on the OMA as well, that kind of goes into some of those areas as well, that especially if you're struggling in a certain area, if it's medications or neuro or demographics, it has that laid out nicely as well. So that's another resource that I used for it.
And the obesity algorithm is one I think you keep using clinically, right? Because it's getting updated over time. I think I just got sent the updates for that. So that keeps coming up, being updated as well. So the big question I kept getting was like, what do I do after the exam? People are like, I passed. I feel like I have no idea how to do this. And that's because the exam really is much more academic, right? So you certainly learn all the stuff you need to clinically, but I found that most people hadn't really seen obesity medicine done. And so for me, I knew I wanted to do this in residency. So I did a month elective. I shadowed multiple different clinicians. I shadowed the bariatric surgeons. I got as much exposure to the clinical side as possible. But I know most people find this a little later in their career, not during residency, and maybe don't have that exposure. So if you have the opportunity to like shadow someone in your community who does this, I think that's great, but that's not always an option. And so that was part of why I created the course that I did, which really is designed to start people from beginning to end of how to see people clinically, with how you do an intake, how you look and address underlying causes, how to talk about medications, how to talk about exercise, how to talk about nutrition, and gives you some handouts that you can just get people started, how to handle eating disorders, how to handle maintenance visits, and then a little bit on the business side. So it was really like, here is your all the things, all the questions I've been answering for like the last 8 years. Here it all is in one place. And it has all the handouts as well. So you don't have to like recreate the wheel, but they're just in a Word format. So if you want to update them to things that are more appropriate for your patient population, or put your logo on it, you can do all that. So that was kind of the solution I came up with for, constantly people like, what do I do now? What do I do now? There's also patient videos in it, so you can see how these conversations happen in real life. So that was kind of the solution I brought to the table on that side. I think the conferences are huge. I usually go to the OMA meetings, and the chance to talk to colleagues at those is huge. You get more in the side conversations a lot of times than you do, at the lectures. The lectures are all great, but, you sit down to lunch with people and you learn about how they're using different generic combinations of meds, or maybe how they've incorporated videos, or how they've incorporated handouts, or what apps they like. And the conferences are just gold to network with people. So I highly recommend, if you get the chance to do something in person, you'll really get a chance chance to talk to some experienced clinicians who can guide you at those meetings as well. And like I said before, it's such a positive group of clinicians that most of the time, people want to share their experience. There's like no competition in this field because we all know that there's so many patients who need our help that we're very collaborative in my experience.
Yeah, absolutely. The conferences they're just fun. I feel like always, if you come out into the common areas, there's people just always talking about different things in their practice and how they're incorporating it. And so I think that's great. I was mentioned too, if I would have found Carolyn's course before, it would have saved me tons and tons of time. I'd kind of got started. Actually, it was a surgeon that approached me and asked if I could help out with the pre and post-op bariatric follow-up visits and making sure that they're ready for surgery and getting all the check marks done. And I really had no experience in that. I came fresh out of residency at that point and was trying to figure things out. And so I took, I went the ABOM route to get some information, but really I was compiling all these templates and trying to get all this patient instruction stuff on my own. And I always say I would have saved a ton of time if I would have known about Carolyn's course before, because it puts everything in one nice package in terms of that, and makes it practical too. And I totally agree. You take this test and it's like, all right, I passed, now what? What do I do? And so that can kind of be the component. I will say too, once you start practicing obesity medicine too, you don't have to be perfect at first. It's not like you have to meet this big threshold and then you can start practicing. I think that's kind of a misnomer, and really your patients are ready. If you have a primary care practice already, whatever aspect you're seeing patients in, anything that you introduce in small areas and just kind of grow and improve upon, the patients aren't expecting you to be perfect in this area as well, but they can tell when you want to help, and I think that's a really important thing, is don't feel like you have to do all of this stuff and then you can begin your practice or incorporate it into your practice. So
that's so huge. And things keep changing, right? Like the way I practiced obesity medicine 2.5 years ago is different than how I practice it now. So it's an evolving field. So I guess in summary, we talked about is practicing obesity medicine worth it? We talked a lot about the satisfaction side. Financially, the demographics that have been done before kind of showed that most obesity physicians are making about the same they do in primary care. So it doesn't always, translate to a change in income for most people. That being said, there are ways that people can make additional income above and beyond that in this field. And many people have through meal replacements and supplements and other programs that they create in coaching and things like that. So, the world is always your oyster if you're, creative, but on average, if you're taking insurance, expect that your payment is going to be, similar to primary care. Job opportunities, this has changed. There's starting to be lots more job opportunities in this field. So a lot of bariatric programs are wanting an obesity physician on their team to help with management before and after surgery. So I think that's become like a really big opportunity over the last several years. And then a lot of telehealth companies are now also hiring in this space. So a lot more job opportunities than there was, a few years ago. So I think we covered the, do I need to take the exam, and I think one other thing that I would add to that I don't think we said is, if you're not in a primary care specialty where, obesity is something you're dealing with on a daily basis, then that may be a good reason to take the exam. For example, if you were coming from radiology or something, I think that would be a good place to start, because you really want to make sure you have that foundation. If you're already an endocrinologist, like, you may not feel like you need, that foundation to go ahead and get started in this field. So I think that's another thing to consider. So the details on the exam are on this slide. This is on ABOM's website. And essentially, you have to do 60 hours of CME. Half of those have to be specific ones that they sort of recommend, what they call these category 1. And then the other half, the other 30, can be the category 1, or can be essentially anything that is a accredited CME course that has the word obesity in the title. So that gives you a lot of flexibility. So I would recommend, doing a board review course, but using the rest of your CME that you have to get anyways to really dive on topics that you know are going to be important for your patient population. So if you know you're not going to do pediatrics, don't go take a bunch of pediatric CME, right? If you, feel like you want more support on diabetes, do a bunch of CME that has, diabetes management. If you want more mental health or eating disorder support, do some of those CMEs. So I think, the 60 doesn't have to all be board prep. Do the, 20 or something of the board prep, and then use the others to help yourself really expand your horizons and feel ready to treat.
And I think as far as the OMA one goes, it's about 12 credits is the board review, the dedicated board review. So you have a lot of other credits to go into different areas, and there's a lot of different options that are out there, and I agree. It's find what's going to work best for you in terms of what your interest is and what you're going to be doing with patients.
Okay, so I think we covered most of that. And then after you pass the exam, a lot of you just passed that recently if you took it, don't be afraid to announce that, like whether that's on Facebook or LinkedIn. If you have a clinic, in your clinic's newsletter or on a little thing at the front stand of your clinic at the check-in desk. But I think it is something you should be proud of, you should announce, and that will start opening conversations in your community and with your patients. And then I would practice what is called your elevator pitch, explaining what it is and why you do it. So I always say, I treat obesity to help treat and prevent medical problems. And I do that through identifying underlying causes, helping patients come up with nutrition plans, coming up with an exercise plan, utilizing anti-obesity medications, and helping with behavior change, right? And people are like, wait, what? There's medications, right? I think everyone knows there's meds now, but they'll zero in on, what's your favorite nutrition plan? And usually ask follow-up questions, but, come up with your 30 to 60-second explanation of what you do as an obesity physician.
I'd say if you have a practice with other providers with you as well, it's kind of fun because people know that it becomes your interest and you become the obesity medicine guy or whatever, and so they'll come to you asking you questions as well, and you can really have an impact in your whole practice in terms of being able to answer those questions and being able to provide some guidance if others have questions in your practice. So I think it's a lot of fun to be able to be that person that people come to, and so letting them know what you're doing and that you pass boards and all of that kind of jump starts that and makes it easier to have those conversations.
All right. So we'll kind of open it up to questions, which I know there's already a bunch in the chat and in the Q&A. Hopefully you can see those too, Kevin, but I'll ask them all out loud. But here's our contact info. I think I put it in the chat earlier, so hopefully you have those websites. But my website's helpyourpatientsloseweight.com. And that's where you can find my course, information about practice consults. I started a mastermind for this recently. The Dr. Francavilla Show podcast, I'm super excited about. It's been wonderful so far. Check that out. Share it with patients. It may speed up a lot of your conversations. A lot of my colleagues are saying they're sharing the podcast that Angela Fitch and I did about medications, just like with their patients. They're like, hey, here's a little bit, go listen to this podcast. So that one's a great resource. And then I'm on the social stuff as well. Kevin, where can people find you?
So you can either find me on Obesity Medicine Review. There's a contact form on there, or just emailing me at obesitymedicinreview@gmail.com. And any questions, anything related to the boards, anything like that, I'm happy to answer. And then you can also get if you're interested in the books, you can get them there. The new edition now it went from 435 up to, I think, 525, so almost 100 extra questions. That's based off of people who have taken the exam recently, kind of reaching out and saying, hey, this is an area that was a newer area that we could add questions to. So it's kind of molded into that and really focused on helping pass those. The blogs are also on there, and you can sign up for subscribe to the blog, so they just get sent to your email as well weekly. They come out every Sunday.
Awesome. Okay, so let's see. I'll take a look at the chat first. What if you only maintain certification through NBPAS? I don't know what that is off the top of my head. I'm going to have to look that up. And then the next question is the most common question I have gotten in the last 2.5 years, which is, can you have an obesity practice that's fully remote? I think yes and no. So the big challenge with this is controlled substances, which I do think are an important part of treating obesity. We have Vyvanse, which is for binge eating disorder and is an amazing drug. And then we have phentermine and all the other sympathomimetic amines. And for the last couple of years, as telehealth has been utilized during the public health emergency, the DEA did not require a face-to-face visit before prescribing those meds. That is, as of right now, it's March, that is going to go away in May of 2023 when that DEA policy goes back to its regular policy when the public health emergency ends. So you would be limited in your ability to prescribe controlled substances, which in my opinion are an important part of obesity medicine. But if you wanted to use only GLPs and Contrave and Plenity and non-controlled substances, and we're clear about that and screen to patients like I think some telehealth companies are doing, then you could be completely remote. You could also be predominantly remote. I just had a nurse practitioner start with my practice, and she's going to be pretty much entirely remote, except for those appointments where she does need to see someone to initiate the medication. So she'll just come into the office like twice a month to do all those visits. So that was our solution. So I'm hoping someday to actually create a telehealth package where you can just start your own telehealth practice. The more I say that, the more pushes me to do it because people keep asking me about it. And I think in that, I would recommend that you have the opportunity to have some office space where you can see people in person so you can use those meds. Otherwise, you're going to be limited. You're not going to be able to use controlled substances unless that law gets changed, which at one point it looked like it was, but I think at this point it's only going to change for like Suboxone, and those medications. So we'll see. It's a little bit of an unknown, but you might be a little limited. And there may be specific laws in your state about telehealth and seeing people in person at some point. There are some states that have those laws. I imagine those will get repealed over time, but I'd always check in your state to make sure you don't have to have that in-person appointment at some point, because that has been a requirement even without telehealth, some places. Do you have any thoughts on remote practice, Kevin?
No, not really. I do some follow-ups just because it's convenient, but I do like to, especially if it is controlled, have them come in, do a weight check with a consistent scale as well. But we have done some in between that are just more follow-up, seeing how they're doing, checking in with them, which has made that part a little bit more convenient as well.
Let's see. Practice outpatient primary care in the DPC and end up doing a lot of obesity medicine as a result, and resources that help link mental health and obesity. So, I think in my practice, there's treating the depression and anxiety and PTSD and all those things that can be a challenge. And I think sometimes we can be a great person to do that because we can kind of keep in mind weight neutral meds, utilizing metformin early on if we're starting a med that's in the antipsychotic family and we know may increase the risk of weight gain. And then I think becoming familiar with eating disorders. There's starting to be more and more training. The OMA's had a few lectures on that more recently. They've been having more mental health talks, and all the OMA talks are on their OMA Academy. So you can go buy things a la carte if there's specific talks you want from them. So they have had some really good mental health ones in the last couple of years. And then I think learning more about binge eating is super helpful. There's an hour in my course that's about treating eating disorders in the context of obesity. So I think that there's more and more training out there on that. I like to have a go-to. So my go-to for binge eating, which is the most common one that is in obesity clinics, is the intuitive eating workbook. So for people who struggle with emotional and other loss of control eating, I think this is a great workbook to read for yourself, and it can give you some ideas for patients. And then sometimes I'll have patients do this, and every visit we're sort of like, okay, let's do the next chapter, and what did you learn? So the intuitive eating workbook, I think, is a great resource for that eating disorder world.
Let's say too, if you have, I think it's good to find what your resources are in your community as well, because there may be specialist psychologists that do CBD training and things like that regarding food patterns. And so if you find those resources and able to utilize them, and if it's not something that you feel comfortable taking on all at once, being able to find someone to partner with, especially for kind of that ongoing therapy part, if there's underlying eating disorders and things like that. Same thing with psychiatry as well. There's a lot of connections. And so I've met a couple psychiatrists that work outside of the OU environment that have, we kind of exchange patients back and forth in terms of that, and it's become a really good relationship. And so finding resources in terms of people as well, I think is good from a bariatric surgery standpoint to psychiatry and psychology and therapy, can really help maximize your benefits that's for that patient, since sometimes those do take a little bit of time to work through it as well.
And then the other very common question I get, which is, can you do only a cash-based practice? And this one always cracks me up a little bit, because when I started in obesity medicine 10 years ago, that was all there was. So my mentor, Becky Andrick, who's now our advocacy chair for the OMA, she was like the only one I had met that was taking insurance. So it's actually, as we've declared obesity a disease and changed our mindset, there's been a huge shift to incorporating this into a medical practice and taking insurance. Which is amazing and I think incredibly important. But yes, there's a very long history. I would say that this was like the original like cash-based medical practice was bariatrics. And so absolutely you can do a cash-only practice. Cash-only practices are going to take longer to build. You're going to have to do more marketing, more networking, and work a little harder to get your patient base than if you take insurance and you can get referrals from colleagues. You can be busy almost immediately if you take insurance and do a little bit of networking and advertising. Cash, again, you're going to have to set yourself apart a little bit more from a lot of the noise out there around weight loss, but you absolutely can take cash in this field. And, like even 7-8 years ago, the majority of people did, but it's been great to see that shift to people taking insurance. All right, there's a few more in there I might get back to, but I want to make sure I look in the Q&A too, because I know people were asking stuff in there earlier too. I noticed there are some postgraduate training positions in obesity medicine now. Do you anticipate ABOM will require this in the future? So I think we're talking about like fellowship opportunities. So there's been a rumor for 10 years now that this is the last year you can take the ABOM exam without a fellowship. That rumor has been going on for 10 years, which was great, I think, to push us, to like take the exam as soon as possible. I've not heard any thing credible that is changing anytime soon. I think it would be great if someday this was considered a specialty, at that same level, at like the American Society of Specialties. What is that organization? But, for right now, I don't think that that's a requirement that's on the horizon, at least in the next few years. It's possible someday, but there are more and more of the fellowship programs that are coming to be. And I think that, again, if this is what you want to do research in the field, you want to do only obesity medicine, you want to be on the more academic side of things, those fellowships may make sense. But the majority of people, I think, the ABOM exam is going to be enough of a pathway for you to practice obesity medicine clinically, because again, there's just not a capacity for everyone to do a fellowship. So again, as far as I've heard, it's just, kind of rumors that the fellowships are going to be required. I don't think that that's on the horizon, at least in the next few years. And, I think there's just not the capacity for all of us to do a fellowship. Have you heard any other rumors about that, Kevin?
Just the rumors, nothing in terms of that.
It's been a rumor for at least 10 years. So, and again, when I've asked and I'm starting to know people who know people, I don't think it's on the horizon anytime super soon.
And I think there's just so many people that are out there already, having a private practice and things like that, that stopping at going to a fellowship is not as practical either. So it would be, I think, popular in maybe new resident grads and things like that. But I think really this pathway allows everyone to be able to do it regardless of what your background is or your specialty.
So next question, doing obesity medicine, do you practice traditional model, DPCR, concierge? All the opportunities are available to obesity medicine. I think it works well in any setting. I'm a big fan of like autonomy and like practicing the way you want. So obesity medicine can work in any settings. There's academic institutions, there are big hospital systems that have it, private practice, cash-based membership. You really can do all of that. When I do private consults with people, like I work out what model makes sense for them and their values and their style. I always caution people that obesity medicine is not, I think it can be really challenging with a DPC, because with the DPC, you are relying on, like $100 monthly membership to cover everything for that patient. I think obesity medicine, at least for the first 6 to 9 months you're treating someone, is often a lot more involved than that. And so I don't think you can put it just right with some of these lower priced memberships. And get paid sufficiently. But you can always add a package on top of that, or have a separate track for a DPC model. So really, like any model can work for obesity medicine, and there is someone who is doing it in all of those different ways. This looks like a question I wrote because there's the word like in it. Like, doesn't everyone just ask for that as a management for their condition? I love it. So asking about if Mounjaro, Wegovy, Ozempic, if everyone is just like asking for that. What are you seeing, Kevin? Do you have people just like coming in asking for the newest, latest thing, or?
I have kind of a mixture. I have a lot that don't know what's out there, but there's just become a lot more publicity with these newer ones coming out. And so I have, a lot of times there'll be an intro to it. They'll ask about it, like, is this something that I could do? A lot of it depends on their comorbidities and just their insurance coverage as well. And so it really depends on that. Obviously, we use a lot of these for diabetes as well, and some of them are only approved for diabetes. So, if they have a concurrent comorbidity like diabetes that you can use it for and bill for and have insurance cover and get the benefits of the weight loss, fantastic. I think a lot of the patients that do come in and they don't have diabetes and they may not have insurance that covers it, it's often a shock to them, the price of it, and then it allows us to talk about some other options that may fit with them financially. But I think it definitely is brought a lot of people in terms of just asking more about it, or is this something I could do, or I've seen a lot of ads on this, can you tell me a little bit about it? And really it's a great avenue to be able to discuss those and some other medicines that are out there, the tried and true ones out there as well, if that isn't an option for them.
Yeah, I have a couple patients that I recently have started on, like Wegovy or Mounjaro, Ozempic, these injectables, and they didn't really like it. And then I ended up starting them on like phentermine and metformin, and they've had like 20% weight losses and are like happy as clams. And so it's just kind of a reminder that, we don't know what medicine's always going to be the best fit. You're going to get more reliable, consistent results with Wegovy. But there's still a role for the other medications. And then affordability is a huge issue still. So I did have a patient last week, I think, come in and she was like, oh, my sister's on Mounjaro and she loves it. Can I get that? And I was like, no, sorry, you have Medicaid and Colorado doesn't cover any of those. So would you like phentermine? So, it is kind of a challenge that the cost is sometimes prohibitive, but at the same time, for those of us who've been doing this a while, like we know that like phentermine and Contrave and like these other meds also work and have great roles too. And so, I think it's just adding to the buzz in the field and getting a lot more attention. And I think it's just a overall really positive thing. And just like anything else, the US is weird, right? Because we advertise drugs in this country and most of the world doesn't. I'm sure this happens to like rheumatologists, right? I always see rheumatology drugs on my TV at least. And like, I'm sure patients come in and be like, well, should I be taking whatever, the newest thing? And they're like, no, like your methotrexate is great. Keep it, like you're controlled, right? So, it's these conversations that we have as physicians of like, what is the best med for you? And that is sometimes more than just, the newest, most expensive med.
They can go both ways too. I've had a number of patients that come in and say, I had a friend on Ozempic and they had a whole bunch of stomach issues. I don't want to even talk about that one. It's like, well, maybe this one will be an option for you, as you go through it. So it really, it's kind of like bariatric surgery too, right? Most people know someone who had surgery and either had a really good outcome or maybe had some weight gain afterwards. And it kind of alters their thoughts when they come to you, and kind of allows you to discuss and try and open up their mind if they're closed off or vice versa. And so, but yeah, it's definitely going to be more common as we see it, as other either family members or friends start these medicines and they talk and reach out to them.
This question was if overseas doctors can take this exam. And I'm trying to look up the answer to that because I don't know for sure. Kevin, do you know?
I think it's only the US and Canada. There
That's
are some other
I thought.
options that are out
Oh,
there,
that is, yep,
um,
US and Canada.
but so I think there's like the scope, and there's a couple international organizations that you can look into as far as they have programs that you can get either certified or get credentials in that. And so that may be something to look at if you don't meet criteria for the ABOM.
And then this question was what time period do you have to earn that 60 credit hours? And you will have 36 months. So 3 years to earn all of those. So that's quite a lot of time to do that. But I think a lot of people do it within a year time frame. I think is the most common that people will kind of decide, and then they take the next closest exam. And you don't have
And
to
there's a lot
memorize
of
all that CME, right? You just have to take it, pass the test for that CME, check it off the box. And what you really need for the exam is the review course to pass the test. And then the CME is really for you to become competent.
there's a lot of free options out there too. Those group 2 CMEs, the other 30 that you need, it really can be any AMA level 1 credits that have the word obesity in the title. And so there's, ACP and AMA and a whole bunch of organizations have lots of great resources too. So it's not that you have to pay for every single one of those either. There's a lot of great free options out there.
Yeah, actually AAFP just had a new obesity course come out. I was the nutrition lecturer for it. So I know there's an AAFP one now, if for some reason, you like to do it through the AAFP. So yeah, tons of CME options out there. What ratio of in-person to telehealth do you see in obesity medicine? What do you think your ratio is?
I would say mine is probably 90% inpatient or in clinic, or maybe even closer to 95%. I do probably a majority, unless there's a reason that they can't make it to the office, or if it's convenience time wise, if they need refills or something like that. I generally just do more in the clinic. I know that varies widely across the board, but that's usually my just with how my practice is set up.
Yeah, and there's various reasons, not all states have parity, meaning insurance may not pay as much for a telehealth appointment as an in-person. So that may be a factor. We've had that in Colorado for a really long time. So I get paid the same in-person versus telehealth, but that may not continue to be the case for everyone, different places. And if you're someplace that has a facility fee, then I guess they like it in person as well, so they can get the facility fee. I think mine's like half and half right now. It's pretty close to half and half. My patients seem to have a preference to see me in person, but I've started to get a lot more patients that live an hour plus away. And so we do predominantly telehealth for our patients that are not close. So a lot of my patients do love to come in clinic and get on my scale and see me in person. That's like part of their process that they enjoy. But if it was up to me, it'd be like 80% telehealth.
And another thing too, and just when I do my dedicated obesity clinic day, we have dietitians and the surgeons that they're all seen on the same day. So it's kind of just a rotation through there. And so that's probably why mine's a little bit on the higher side as well. I will say as well, if you're going to do telehealth, I would recommend trying to make sure that they can do virtual visits. If you get the telephone, our pay is extremely low compared to actual telehealth visits. And so you always get those people, sure, I can do a virtual visit. And you call and it's like the camera doesn't work, their phone's not working, and they convert it over to a phone visit or want to, and it really is not the same. It's not going to be financially feasible if you're doing a significant amount of yours that end up being those phone visits.
Yeah, I think, like you said, a lot of it's going to be patient dependent, right? If you're in a place that does not have great internet access, or you have a patient population that's not as tech savvy, doesn't have, high speed internet, or doesn't have the technology, isn't comfortable with the technology, they're not going to want to do telehealth. If you have a patient population who likes that, who travels a lot, who doesn't live close to you geographically, then you're going to probably utilize telehealth a lot more. It does let you be more efficient with your space. So we have 4 docs in my clinic and now a nurse practitioner. And because we utilize virtual care so much, we are able to do that. None of us work full time with 5 exam rooms. So we have 5 clinicians and 5 exam rooms because we utilize so much telehealth. So it makes you need a lot less space to do virtual as well. So that can decrease your overhead quite a bit if you're in your own practice. How many patient appointments do you see in a day? So you had like a dedicated obesity clinic day. How many would you see in that day?
I usually schedule around 10, with 2 or 3 being new patients. And that varies. I will say, I think my days that I do just strictly obesity medicine, especially new patient appointments, I feel like some people get cold feet. And so sometimes the no-show rate is a little bit higher for those new visits. The follow-up visits, usually they're coming in and they're excited. And so those tend to be more reliable, I think, in terms of that. But usually they schedule about 10, sometimes a little bit more, just planning on some no-shows there as well.
So I get almost
And that's, sorry,
no
that's for a
shows.
half.
So like, oh yeah, no shows, which are not always bad. You know, if you're employed, no shows might be great. In private practice, you don't want no shows because you're not getting paid. So I have really strict policies about if you miss your first appointment, you can't reschedule. So it's super rare that my first appointment's no show, because then they like, you don't have to find a different clinic. But when I was working regular days, I kind of work shorter days right now because my kids are in school. And I would see about the same 10 to maybe 12 in a day, and really just like 1 or 2 new patients because they take a lot more effort. So I think the volume tends to be a little lower than a lot of primary care because we tend to be a little bit more intensive with counseling in this field. But I have colleagues who like see like 30 on a Saturday morning. Like they just do a bunch of follow-ups back to back and are super efficient. So there's different ways to do it for sure. But I think about 10 to 14 is probably the max that most people are seeing in this field. Again, unless they have like a lot of support and a dietitian and other people who are doing a lot of the care. All right, let's see. Work-life balance schedules, what salaries? So I think we kind of covered that after that was asked, which is most of the time we're seeing that salaries and pay is very similar to primary care pay. Would you agree with that, Kevin?
Yeah. And I think that's maybe from my standpoint too, because there's a lot of crossover between that, and mine's an academic setting, so it's a little bit structured differently as well. But as far as I can see it across the board, and when this stuff comes up on Facebook chats and stuff like that, it seems like it's pretty similar across the board.
Yeah. The OMA did a study maybe 5 years ago, and it really showed that there was a huge distribution. Like most things, men made more than women, as I recall, and that it was very similar to primary care salaries. So I think that there could be change, but because most things are billed similar to primary care and under primary care coding in the insurance world, if you're dealing with insurance, you're going to make probably similar to primary care. There's definitely a lot of people, especially on the cash side, who have really successful businesses. And so, there are lots of people who have done that. So, the world is your oyster when it comes to, being an entrepreneur. And I think work-life balance is really great in this field. You basically don't need to be on call for obesity medicine. You're really not going to get any emergent calls about obesity medicine. So I think that is super helpful. You can kind of create your own schedule. You're not doing procedures or surgeries or anything. You can do a lot by telehealth, which gives you a lot of flexibility. And I think you can do a lot asynchronously. So I've started to do a lot more by like text and messaging with my patients, which is working really well, which gives me a lot more flexibility as well. So I think there's a lot of potential to make this field what you want in lots of different ways.
I think I see more people jumping out and doing obesity medicine clinics and starting their own clinic in that avenue, rather than if they're going to do their own private practice and start their own clinic from that. I feel like it gives them an extra tool, an extra avenue as well. So if your primary goal is work-life balance and you want to be able to make your schedule and run your own clinic, I feel like a lot of people feel more comfortable doing it with an obesity medicine background as well, rather than maybe just jumping out and going into full-on primary care. Is kind of what I've seen as well. So it gives you an extra tool, an extra revenue stream, or a stream of patients anyway, that word travels quickly, and you can really fill up your practice quicker as well.
We had some from email that I want to make sure, because I said we'd answer. Question about pediatric population, which Kevin, are you doing any peds?
No. No.
So I do pretty minimal peds. I think pediatric obesity is challenging and really takes the right touch and the right setup. And it'll be interesting to see how things play out, because there's a lot of new recommendations to be more aggressive with treating pediatric obesity. So for me, in my practice, I do primarily adults. Really, the only kids that I see are kids of parents that I'm working with, which, as a family physician works well for me. I like to take care of the whole family unit. So I, personally, I'm only seeing kids if I'm seeing their parents, because for a while I'd have people bring their kids in and they'd be like, well, they just won't do this and they need to do that and blah, blah, blah. And it was a very uncomfortable dynamic. And so I like the whole family to be on the same page and making change together. So that has been my practice. So my pediatric patients are fairly limited. Question about dietitians. This is a question we get a lot. Like, do you need a dietitian? How do you utilize a dietitian? I think in the insurance world, dietitians can be a little challenging, because there's really only specific things that insurance pays for with dietitians. And so, right now, you can't really get reimbursement just for obesity care with a dietitian. They have to have diabetes or other qualifying diagnoses. So in the insurance model, having a dietitian can be a little challenging. You have to be a little creative about how to integrate that into your clinic, or have a high enough volume of qualifying diagnoses to have that dietitian. There are some people who utilize it in different ways. Jennifer Paisley, I have to get her a shout out. She perfectly described how I do nutrition in my clinic, which she's like, I have this nutritional coaching philosophy. And I was like, I'm going to steal that. That's how I do nutrition in my clinic. I coach people on nutrition. What are you eating? How can we improve it? What are your goals? How do you feel? And that's my process. So I don't need a dietitian for the style of nutrition that I use in my clinic. I don't have a dietitian. I do that counseling myself. And the longer I do this, the simpler and simpler my nutrition advice has gotten for patients. Because at the end of the day, it's actually not really about the food. It's all biology. And so we have to use meds, and the food is really actually a small part of it. With new pediatric prescribing guidelines, have you seen many prescribing for meds? I guess I can't say what's going on in the community. I'm guessing that's going to take a little while to catch on, but I think it's super exciting that, pretty much all of our meds have indications for 12 and up now. So I'm very excited about it. I think a lot of people, the patients I've worked with so far, even if the adult in the family is on a med, they're pretty resistant to having their kids start meds. So I think that will take a cultural shift in our society as well, for people to utilize these meds for kids. Let's see. Yes, it will be available as a recording. We're actually out of time. So thank you for joining us. We'll try to answer a few more questions, Kevin, if you have a few more minutes, and then we'll post this recording for anyone who's leaving early. Someone asked about how long of appointments. So I do 60 minutes for my first appointment, 45 to 60 for my second, and 30 minutes for follow-up, but I'm managing primary care for a lot of my patients as well. So I think you could get away with shorter appointment times, 20 and 40 or 20 and 45, if you were focused on just obesity.
That's what ours kind of run, is 40 minutes for new patients and 15 for established. And then we have a dietitian there that also sees them usually afterwards too, to add it into that component.
Let's see. Okay, those ones we already answered. Let's see what else is in the Q&A. There were some very specific business questions. So don't know that I can answer all those right now. Can you complete CME for ABOM prior to finishing residency? Yes, you can. I'm pretty sure that's what I did. So I would confirm that you can still do that. But yeah, and OMA has really sweet resident discounts. So I definitely took advantage of that and did most of my CME before I had finished residency. So you can absolutely do that. Oh, that's okay. I think that actually really was most of it, other than some very specific business questions, which was not necessarily the goal of this particular Q&A. Any final words, Kevin?
Just get out there and do it. It's fun. You guys will enjoy it and just incorporate it however you can. I think, like we've talked about, I think the ABOM is a valuable tool. And so would encourage you to look into that and see if that's right for you as well. And then look at some of the resources that are out there. If you decide not to do the ABOM, just getting those resources. And like we mentioned, OMA is a great example of that. There's a conference coming up here next month in New York. And so not very many conferences are in New York City. So I think we need to take advantage of that, just a fun new environment. And so I'm excited for that. And just networking, being able to ask those questions, get that information that you want to be able to help your patient panel in the best way you can.
Okay, I saw some other questions, which was about compounding. I do not recommend the compounded medications in terms of the injectables. They're unregulated. We don't know what they are. There is not a legal way that people can currently be doing that because Novo Nordisk has the patent for semaglutide. I think there will be a position statement potentially about that sometime soon. But not recommended. So I would say no to compounded, and your patients are going to ask about it and you have to be able to tell them, why you don't recommend that. CME. So after the exam, you can either take the exam, I think every 10 years, or you can do a CME that is journal articles on a 2-year rotating cycle, I think. So you can do a journal pathway, which is very, very easy to do and not stressful and very educational, or you can take the exam again after 10 years. So, so nice options there. And then someone was also asking about different organizations. So OMA, OMA is how I got introduced to this field. It was the American Society of Bariatric Physicians. I loved it. I'm now on the board because it's just such a wonderful place to be. Great clinicians. I think we're doing great things education-wise, but obviously a bias there. Obesity Society. I went to my first Obesity Society meeting this year. Very different, much more academic, research-oriented, much wider group of experts. Lots of PhDs and researchers there. They have a great, journal that has all the data. So, with the membership, you get the journal, so they're a pretty cheap organization to join. So I think it makes sense to join that one. And then ABOM, again, is how you take the exam. So if you want to be a diplomate of the American Board of Obesity Medicine and call yourself an obesity specialist, then that is the path for that. And of course, if you're asking about groups to join, I would always recommend joining the American Medical Association because they are our best advocates, no matter what you've heard. So yes, thank you guys for joining us. Again, this really is such a phenomenal field to be part of, and it's an exciting time. We are just seeing new guidelines, new medications, new acceptance of treatment. And I don't think that there's really a better field you can get involved in, whether it's just adding it a little bit to your clinic or going all out and, specializing in it full time. So keep in touch with us, check out the review books, check out my podcast, and we hope you all learned a lot, and we'll connect with you virtually.
Thank you, guys.